Hello everyone. At the outset, I would like to thank YOSI for this wonderful initiative on ocular emergencies. And today, myself, Dr. Deepti Joshi, would be talking on sudden onset esotropia in children. So, let us start with this case of a 10-year-old girl who presented to us with diplopia and sudden onset left eye esotropia since past 15 days. On examination, her vision is perfectly normal. She is 6 by 6 N6, cycloplegic diffraction, nil significant refractive error. Ocular movements are perfectly normal and fundus absolutely normal. So now, how would you proceed? Well, with the digital abuse after COVID infection, this has been a very common case in our pediatric OPD. So if you see any child with sudden onset esotropia, if there is an abduction restriction with or without papilledema, always consider it as a sixth nerve palsy. Could be viral, could be due to intracranial cause. But if the movements are normal, then proceed with cycloplegic refraction. If there is a significant hypermetropia, consider it as an accommodative esotropia, prescribe glasses. Well, if the movements are normal and nil significant hypermetropia, then consider it as an acute acquired comitant esotropia, AACE, which is a new topic for most of the postgraduates. So what exactly is this AACE? Well, these are some sudden onset esotropias associated with diplopia. They are relatively large angle deviation, minimal refractive error on cycloplegic refraction. The versions are absolutely normal, especially abduction. There is no papilledema. Clinically, they have been classified into 7 variants. But for exam purpose, if you remember these 3 variants, which is type 1, the SWAN type, which is usually seen after occlusion in case of amblyopia management. Type 2, which is Burian-Franceschetti type, which is stress-induced, could be physical stress as small as a fever or psychological stress like an exam-induced. Type 3, which is Bilshowski's, is usually refractive error or moderate myopia associated. The next question, if any child who presents to you with sudden onset esotropia, should it be subjected to neuroimaging? Well, as I already explained, if there is a restricted abduction, whether there is a papilledema, disc edema or not, always consider it as a sixth nerve palsy. A mandatory neuroimaging has to be done. But the question mark cases are these acute acquired comitant esotropias. In these, if it is isolated, a neuroimaging can wait. But if it is associated with other ocular symptoms like abnormal vision, pupillary reactions involved, when there is a disc edema or the pallor, nystagmus, especially vertical nystagmus or a pattern deviation, or if it is associated with systemic conditions like headache, cerebellar symptoms or other cranial nerve involvement, then a neuroimaging is mandatory. But when in doubt, always proceed with imaging. Management, the most important clinical feature is diplopia. So to relieve diplopia, you either can use prisms, can be Fresnel prisms or the prisms incorporated into the glasses depending on the amount of deviation. Occlusions or the newer modality is botulinum toxin injection into ipsilateral medial rectus muscle. Despite all these maneuvers, if still the esotropia or diplopia persists by 5th to 6th month after the onset of esotropia, then a surgical management either in the form of bilateral medial rectus resection or a medial rectus resection and lateral rectus resection can be tried. So the take-home message is, if there is any child with sudden onset esotropia, please rule out sixth nerve palsy which requires mandatory imaging. In case of acute acquired comitant esotropia, where there is no significant refractive error and versions are absolutely normal, look out for other associated features, relieve the diplopia, and finally the surgical treatment to treat them. Thank you.